We can talk about your interesting life experiences when we talk about your PhD work, because it is 381 pages. I've not read all 381. I'm going to admit that. I'm not going to admit that. But it was a really fascinating read. And I would encourage people listening today to read as much of it as possible, all the publications from there.
That's very kind of you. Thank you.
No worries. For those listening, liver transplantation has been going on, partial lobe transplantations and even marginal. And then your work was to use discarded grafts and then allow them to be transplantable. Yeah. And the reason that's the case is there is a problem with long waiting lists. Yeah, many patients with chronic liver disease waiting for liver transplantations. Absolutely. And you have these number of unused organs that are not being used, or many patients, do pass away over 60. And by then you develop, comorbidities and liver disease. Yeah, but then it makes it functional for those patients to be used. Donor quality is not
improving. It's not with as a country. We are thankfully, health and safety is paramount. We thankfully don't have, as many young deaths as they do in other countries. Yes. But as a result, the donors that come through are comorbid generally. Yeah. The livers are becoming increasingly fatty. Mm-hmm. And those fatty livers are at high risk of either delayed graft function or primary non-function, where they don't work at all, or post-reperfusion injury. And so, all these, this is not a problem that was going to go away anytime soon. Yeah. And there are increasing indications coming on board, like colorectal liver mets for liver transplantation. Okay. Cholangiocarcinoma in certain circumstances. So. Okay. The number of indications are increasing. Yeah. NAFLD is an ever-increasing pathology which we're dealing with on a day-to-day basis, and the nation isn't getting any fitter.
No.
So, both the causes of cirrhosis, the causes of liver cancer, they're all going up, and the number of donors are coming down, and the number of quality donors are coming down. So, efforts are being made globally to try and help sort that balance out. And in the UK, we don't have a big living donor program. Virtually all of our transplants are deceased donor now. Mm-hmm. It was. I'm very grateful for having been a part of a trial which has undoubtedly helped change practice.
Yeah, exactly. Yeah. In terms of creating the vital criteria, because it's such novel work, how do you formally say this is the lactate level, or this is the amount of bile production we use? How do you formally say that?
I'd like to say it was really high tech, but it wasn't. I mean, it was a case of what would we expect a working liver to do once it's transplanted? Okay. So we want it to make nice bile. We want it to have low resistance throughout the liver tissue, and not have very high, resistance, low flow rates through the artery and portal vein. So we picked physiological parameters: 150 mils a minute minimum for artery, and 500 mils a minute minimum for portal vein. And we want to see metabolism of glucose. We want to see a liver that's metabolizing glucose. We felt that metabolism of lactate was probably the hard criteria for us, but there are other groups out there who are saying that's not important. Okay. So again, this is part of the rich tapestry of academia, and it's important, to have these different voices, even though they were wrong.
Yes. Even though this all worked out exactly.
Well, there's still people out there who don't believe lactate metabolism is. I mean, it is a complex issue. I'm not saying that it's straightforward, but for us, we felt if a liver is chomping through lactate and bringing it down to normal levels within the perfusate, within half an hour, then and we extended that out as we became more confident to 4 hours. Okay, but generally it was 2 hours. We looked for, and actually, if you put a good functioning graft on a machine, it would bring it down within 15 minutes.
Right.
Okay? Right. So, other things came into play, like insulin resistance of grafts in patients who'd had type 2 diabetes and were obese, and so there was lots of other possible factors at play. And even now, we've submitted a paper which looks at the metabolomic profile of these grafts from the Vital trial, and it's only now we've managed to get all of the analysis done, and that will come out and hopefully paint because what we really wanted to do was to have ideally a point of care test where you just dropped a bit of perfusate onto a sensor and it gave you a green light. Yes, you can use this. It's got the right metabolic profile, right proteomic profile.
Yes. So,
but this is for other people to take forward,
of course,
who are much more intelligent. I think I was fortunate to come out at a time when things were developing, and I'm very proud of what I managed to pull together for the thesis. And there were some other bits in there about stem cell therapy and Hemopure, which is this bovine oxygen carrier and things like that, fractionated hemoglobin.
Yes.
So there were some really interesting parts to it.
And the normothermic perfusion machine. Did another team create it specifically for liver transplantations? Because that's not a new novel machine that's been used, from my understanding, in cardiothorac surgery for heart transplants.
So there are ECMO devices which kind of will help on a much larger scale take over heart and lungs and things like that. It's essentially a shrunken version of that. It's got an oxygenator. It's got a pump. Mm-hmm. And it's got some sensors, and it's got a basket for the liver, and that obviously there are much more complex issues at play, and in some of the other devices which are much more automated, there's a lot of sensors that are going on to change parameters here and there. But the concept of organ preservation and organ perfusion has been around for decades. It's just only recently where technologically they were able to achieve it to a consistent to a consistent degree. So again, there's various companies that have popped up. You've got Organ Assist from the Netherlands, which have made the liver assist, but they do one for kidneys. They do and Organox, I think, also has a kidney device now. There's a Transmedics, or a big American company. They have liver, lungs, the heart. They do DCD hearts as well. Where they have pacing wires sewn into the ventricles and will pump. I mean, it's amazing seeing these devices in action. And the human body is pretty amazing. That you can, the fact you can trick it into thinking that it's been connected into a body, and the organ just starts working is the sort of stuff a little bit from Frankenstein. But it is a beautiful thing to see when you have a liver that was ordinarily going to be discarded, that's come out of someone who has thankfully donated their body to organ donation, and the family have obviously gone through such trauma and have been willing to sort of give that consent that they are willing to for their relative to go through that, and then it then goes on to help another individual lead at times a long and happy life. It is a pretty amazing thing to be a part of. It really is, and that was the real draw to me for transplantation, were the outcomes and this kind of ecosystem, if you like, of donors and recipients. And it was a very humbling experience to be a part of that, and I'll never forget my first organ retrieval. It was a really...
I was just going to ask, can you tell us about the day where the first human liver transplant was done for a discarded allograft? Can you tell us the night before, how you were feeling on the day?
I mean, it's a really nerve-wracking experience, and I used to worry all the time, because even if you transplant a usable graft, the patients can have adverse outcomes. They can have a big reperfusion injury, they can have a delayed graft function, a primary non-function, and we didn't always have smooth outcomes. But I used to be really anxious at the time, not necessarily while the liver was on the machine, but I was apprehensive at times when I was asked whether or not a liver was meeting criteria, because that decision would sort of generally fall to the individual doing the perfusion. And obviously the facts were there, so the consultant could see it. But sometimes they looked to you for reassurance that everything was running smoothly and there were no other issues on the gases that you could see. And then, of course, you'd hand the liver over to the surgeon at the time, and you would just hope that everything went smoothly. And thankfully, the majority of the time it did. But again, it's just part of being this bigger team, isn't it? That we have in surgery, and it's so important. It's a wonderful specialty to be involved with. And I think that's as well what drew me to surgery, was the fact that it is part of, I always played team sports when I was a kid at university, and I didn't want to do something that was quite insular and lonely, if you like. So I wanted to be, part of a wider MDT, because that's what brings me enjoyment. Yeah.
Okay.